EM board bombs. Now, here's Doctors Iltafat Hussain and Blake Briggs.
Welcome back to another EM Board Bombs podcast, where we help you study for boards, but in reality, we help you study for #EMLife, one rapid podcast at a time. But now we should say video cast.
Yeah, this is weird. I'm on video.
And everybody can see our faces. If you thought you had conceptions about how we looked and you've somehow never looked up our photos or seen the photos of us, then here we are. This is us.
Yeah, they might be looking at all the gray hair and saying, this makes sense. They always thought that I provided the most sage advice. And they're going to look at you and they'll say, I knew I shouldn't trust that teeny bopper.
Yeah, the young gun on the show. And all the wisdom and all the dad jokes coming from the gray hair.
There you go. Man, so we are live. It's our first video podcast that we've done, right, Blake?
Yeah. Well, together. I did a silent, soft opening last week without you.
Of course you did. Yeah.
Because you were busy building your studio. I hoped you watched it. I thought you would have watched it.
I've got a beautiful studio set up here, just FYI. Like, they're like lights everywhere.
Did Jaco come by yet?
No, the permit person hasn't come by yet, but it is looking legit. It's looking legit. Okay. All right.
So you're not running a certified operation yet?
No, we'll see. Anyways, we're going to talk about government regulations here.
Hey, for each 10 to 15 minute episode, you gain high yield board knowledge. As we like to say, come for the stems, stay for the content. You can find us on Twitter and Instagram, and now YouTube at EM Board Bombs is our channel. There's no other EM Board Bombs out there. If you just type it in, you will find us. Very unique. Hey, so let's dive into this question stem today.
Sure.
We have an awesome, it's kind of like video killed the radio star theme today, because we're audio, now we're video and audio. Mm-hmm. And so it's kind of, if we took a spin on that title, it's video killed the radio star ... and caused epiglottitis.
Yeah, yes. And I will say, I think majority of our listeners will not get that reference due to their age demographic.
Yeah. Well, we're both Cold War babies, so that's why I like to tell people.
Exactly. Yep. All right.
Yeah, we both were born before the Berlin Wall fell.
Yeah.
Anyway, hey, so the key points here is we want to focus to video to provide better streaming content for our subscribers. And we're on YouTube now. It's a multimedia platform, truly. Yeah. And we're going to show you a typical day in the life for the EM Board Bombs team. We're thinking about doing a Last Dance kind of documentary in the future too, where camera crew follows us along for a year.
And, I think the only issue is ESPN approached us, but our boy, everyone knows our famous director friend.
Chris Nolan.
Yeah, Christopher Nolan. Or Chris, as we call him. He's, I think, a little bit upset right now because he thought he was going to get first dibs. Mm-hmm. So we are TBD.
Yeah, we're working that out. Anyway, hey, why don't you tell us the stem here and let's dive into this topic.
All right, let's get into the stem. A 6-year-old girl presents to your ED with cough, difficulty breathing, fever. Exam reveals stridulous sounds. Lateral x-ray shows a, quote, thumbprint sign. What's the next best step? A, IV antibiotics. B, nebulized epinephrine. C, airway management in the operating room. Or D, IV steroids. So this stem is actually coming from our EM Rapid Bombs podcast. So remember, we've got EM Board Bombs. And then for those who want a little more of a premium experience, getting 4 or 5 minute long podcast episodes, multiple episodes dropped a week. How many episodes are we on now, Briggs?
Oh, we're over 360 episodes.
Over 300. Wow,
easily.
That's a lot.
We're about to hit a whole year's worth of episodes.
That's
incredible.
Amazing. You could literally listen to one episode a day for just general EM content. And it's great. We provide 4 or 5 minute long episodes. We get through high yield sport content, but also just EM life content. It's been pretty cool to, we've got residency signed up, but at the same time, we've got seasoned attendings in all different parts of the world that are using the podcast, which is pretty awesome to see. Mm-hmm. And the biggest feedback we get, it's a great way to just keep up to date on content. You're always forgetting something, right? But it's a good way to refresh things. We've got so many episodes. I even go back and listen to the old ones to keep up to date and to remember things. It's pretty amazing. But
same. I looked up one the other day. We had an interesting case of actually tephlitis.
Yeah.
And no one's heard of it. And I did a rapid on it. So I looked it up to remind myself what I talked about.
Right. And I had one on pediatric hyponatremia and totally, went back to that episode later and reviewed it. So it was pretty awesome. But anyways, you'll see that in our show notes. Our YouTube channel has links to it as well. But if you want to sign up for the EM Rapid Bombs podcast, it's emrapidbombs.supercast.com. That's the premium pod. And we also have a ton of just free content in general, over 100 general episodes as well. But I'm going to get into the STEM. This is a kind of a sneak peek on that premium podcast and how quick those STEMs and question and answer choices are. Hey, Briggs, what's the right answer?
Hey, the correct answer here is going to be airway management in the operating room. We're talking about epiglottitis, as we hinted earlier. And the number one priority here is securing the airway. This is the most classic board question you'll ever get.
Yeah,
ever.
It really is. Yeah, and it's the easy one. And honestly, this is one that might even present on oral boards as well. So
yeah, just a piece of cake, thankfully. So epiglottitis, thankfully, is rare, but it's an inflammatory condition of the epiglottis and the nearby structures. It's a life-threatening condition. It causes significant swelling of the upper airways and can lead to, of course, respiratory arrest, most common cause of death. Now, the interesting thing is that everyone used to be taught that H flu, Haemophilus influenzae, was the most common cause of this. And in the post-H flu vaccination world, where kids are getting vaccinated against H flu, the incidence has dramatically reduced. You may not see this in your entire career. You definitely won't see it if you don't work pediatrics often in a dedicated pediatric hospital. But it's a critical presentation to know because you need to identify it quickly. And like so many questions related to medical emergencies, the speed is going to be important here. How fast you diagnose it, how fast you get that definitive treatment. And you're not going to be messing around with anything else. There's just certain questions on boards that there's only one right answer and there's really no other answer. That's it. So the incidence of epiglottitis is so rare. It's 0.6 cases per 100,000 pediatric persons. So tiny. So its incidence is actually a bit lower than in adults. And adults thankfully have a benign presentation. I've seen epiglottitis in an adult before, and guess what I did?
Yeah, what'd you do?
I sent them home. They did great. Anyway, so
it depends. There are caveats to that.
Yeah, it depends. It depends. You're right. They were like 18. They looked great. Anyway, adults thankfully have a benign presentation, and there isn't much you need to do for adults here if they look well appearing. For sure. Now, with patients, specifically children mostly, that present with the following clinical signs, and by the way, these clinical signs are critical to know because they're buzzwords. And I want Iltafat here to give them since he's so wise and he's always full of wisdom.
Yes. So these key buzzwords are just critical to know because, again, it's another way that you're going to be presented this on a test question. The ones that you're going to need to know, again, is for epiglottitis, especially in that pediatric population: stridor, muffled voice, drooling, tripod position, sniffing position. Frankly, Briggs, these are keywords to know just in general when there's an acute airway emergency as well.
Sure. And oftentimes these symptoms are going to be made worse by agitating the patient. And this can lead to deterioration. This is so true in pediatrics. So everything possible must be done to make these patients comfortable. Dimming the lights, limiting the number of people in the room, not forcing the child to lay in the bed or sit on the bed. If they want to sit in mother's lap, that's great. Fantastic. This is one of those times where doing an exam of the oral pharynx and the tongue blade can make things worse. So don't do it if the child is already agitated and looks like they're having trouble breathing. Now, if the child can tolerate a lateral neck x-ray, you can do this, but it just doesn't change anything. If you have a clinical picture and it's an acute airway emergency, they're going to the operating room. It may not be epiglottitis. More likely it's a foreign body. It doesn't matter. It's going to have to go to the operating room. And on test questions, they will often ask you to identify and recognize the, quote, thumbprint sign, which is indicative epiglottitis. This is such an obvious thing now. I just see it less and less. The more critical exam principle here is recognizing a sick child, recognizing that nothing you can do in the ED is going to save this child's life. And so you have to move forward with providing expert care.
For sure. And I think I'm so glad you mentioned that because look up what thumbprint sign looks like, find some pictures of that. That's great. However, you're not necessarily going to be given that x-ray. And you might, honestly, in the answer choices, they might list, get a lateral neck x-ray as the next best step, right? But don't get a lateral neck x-ray. You need to just move forward. Because in this, question, we gave you the thumbprint sign, right, in the STEM. But again, on answer choices, they're going to give that as one of those next best step options, but present you that acute airway. You should know immediately that this patient needs, OR for airway management.
Yeah, speaking of OR for airway management, why do they have to go to the OR here? What is so critical here that they have to go to the OR versus you intubating them there?
Yeah, this is one of those intubations that if an ED provider is unfortunately having to do a crash airway on, I think we all would be just, we're used to a lot of things. We can run codes with our heart rates in the 60s, 70s, very calm. But this is one of those where that heart rate's going up, right? And it's important because if intubation is not going to be successful, you're going to need to convert it into a tracheostomy or a cric.
Right.
And in a pediatric patient, that is not easy. This is not that, adult patient with a long neck that you can, throw that cric in, right? This is not it. Hey, talk about some of the other answer choices that we gave.
Yeah, for sure. So the other answer choices here, one of them was about steroids. Yes, you should give this patient steroids to help reduce the edema. Sure. And yes, the other choice about initiating IV antibiotics, of course. And maybe you should start trying nebulized epinephrine, preparing for the airway. But the definitive step for this patient, and the end choice said, what is the next best step? And in an ideal world, the next best step is going to the OR. Right. All the other answer choices were reasonable. They're not definitive treatments, though, and they might agitate the patient more, especially if you're sticking them for IM steroids or trying to strap a mask, venti mask to their face to give nebulized epi. It's all silly stuff. Yeah. So unless you have that child going off to the OR immediately, nothing you're doing is definitive. Right.
And sure, start working on some of this stuff. If the child can tolerate it, if things are relatively calm, which, shockingly, sometimes we have seen, there's some kids that just can handle these things like a champ. But at the same time, we were trying to get you to go to the OR as soon as possible. That's going to be definitive management of this, at least in the acute emergency setting. Hey, let's bring this in. Let's summarize all this stuff. Okay, give me 3 points.
Coaching? Are we doing coaching?
Yeah, we're going to do coaching. This is our coaching section.
So excited.
Play that music. Play that music.
Play the little whistle.
We do. So epiglottitis in kids is a terrifying, life-threatening condition. It's critical to just recognize early. Remember those key things that we talked about, those key buzzwords. So stridulous sounds, muffled voice, drooling, tripod position, sniffing position. If you see this, you should immediately be thinking about epiglottitis, especially in the setting of a child who's febrile that might be agitated. If there's time and the kid can tolerate it, you can get a lateral neck x-ray that's going to show you that thumbprint sign. But again, they might not always give you that lateral neck x-ray. They might want you to just immediately proceed forth with a definitive airway because you might not have that time. And frankly, it might just agitate the kid more. At the same time, look up what that thumbprint x-ray looks like as well. That's important to know for boards and just life. Immediately upon suspicion or recognition, you're going to be taking this patient to the OR. Again, surgical teams are going to help you with management of the airway. If the patient's acutely crashing, so they're not ventilating, they're becoming just severely hypoxic, then get ready to intubate, but really should buckle up. I mean, that's going to be the most experienced provider is going to need to be there to help you. And you better be ready to convert that to tracheostomy as well. Right. And by the way, we've got a great airway module on emboardbombs.com that you can actually check out as well. That could help you in a crashing situation.
It's free and open.
Yeah, it is. Yeah, foam.
Yes.
So good deal. Anything else, Briggs?
That's it. Just a pleasure to be here.
Yeah, it's a
pleasure to see your silvery beard.
Yeah, thank you.
Salt and pepper beard.
Salt and pepper. What do they call that? Isn't it this a certain look? Silver. Like I don't know. I think
it's salt and pepper.
Is it just salt and pepper? Is that what the Anglos say these days?
I'm sure someone will comment on it on YouTube.
Oh man, yeah, we got to be ready for that now. Yeah. Right. It was nice to be like in anonymity. I feel like we were just off in our own world. Yes. Unfortunately, we give
now we got to make sure we work out more and
yeah. I mean, it just I don't know about this whole video.
Yeah, go to the beach more. I got to tan more. I look pale white compared to you.
I mean, I got good lighting. So I got my studio set up. Remember, some great lighting. So.
Yeah, exactly. Anyway, hey, we'll see you next time. Thanks for joining us.
See you next time. Check out emrapidbombs.supercast.com. Great way to support the pod. We appreciate all the support and everyone who signed up to support. And that's it.